just be talking about studies that have used psychiatric diagnoses. Just need some help here. So, in summary, I've got a little bit more time than the other speakers, but not much, 15 minutes. New psychiatric disorders after traumatic brain injury. Summary of the field is that after severe traumatic brain injury, half to almost two-thirds of children will develop a new psychiatric disorder. In other words, a psychiatric disorder that was not there before. An example would be a child with no psychiatric disorder develops attention deficit hyperactivity disorder. That would be counted. Another example of that would be a child who has had major depression in the past, develops a new disorder like oppositional defiant disorder. This is important because about a third to a half of children who have any kind of injury, whether it's an orthopedic injury or a traumatic brain injury, or a pre-existing Lyme psychiatric disorder. That's why this field of psychiatry, child psychiatry, and TBI is very connected and very important, both in terms of what happens before, what's existing before in the child, and the consequences. After mild or moderate traumatic brain injury, and there's a difference between those groups, the rates in summarizing the field of new psychiatric disorders is between 10 and 21%, and after orthopedic injury without any involvement of the brain, like a fracture, it's between 4 and 14%. There's a difference between the mild TBI rates and the orthopedic injury rates. Well, mild TBI, I'm not just talking about sports injury here, annual incidence of TBI as a whole is 180 per 100,000, with mild TBI accounting for about 90% of those injuries. The importance of this is that even if there's a small percentage of these children with mild TBI who develop negative outcomes, this would represent a major public health problem. That's probably everyone here realizes that, and that's why we're meeting. Looking at the entire field of psychiatric studies of TBI, and again, I have to emphasize this is psychiatric, especially in Seattle, because Seattle's a place where just a beautiful study of mild TBI and, in fact, the whole range of TBI was done, but the outcome measures were essay questionnaires as a proxy for psychiatric disorder. I'm not counting those over here, but 20 studies over the past 80 years have focused on psychiatric outcome in children of TBI with all severities. And the psychiatric disorder in mild TBI is crazy. It's between 10 and 100%, depending on study design. Example of that would be if you have a pediatric brain injury clinic, which is a very wonderful thing to do, and I'm part of one. People who come to the clinic are not coming because they have no problem. They're coming because they have a problem, and very frequently, close to 90% of the children will have a psychiatric disorder that's complicating their outcome. Sub-studies of consecutively treated children. This is important when you're reviewing the literature. Look to see whether these are consecutively treated children in the studies that you're reading. So with mild TBI, the rates are narrower in these consecutively treated children. It's between 10 and 40%, with a lot of these actually finding higher rates. Mild TBI versus injured controls. There's it's important methodological here, which can be and will be debated. Should we compare mild TBI with injured controls or uninjured controls? There's strengths in both designs. So versus the injured controls, it was the rate of new psychiatric disorder was similar in one study, the famous one from England in the 70s. Was higher, but not significantly higher in two small underpowered studies. Mild TBI versus uninjured controls, it's all over the map. Non-significantly higher in one study from Germany, actually, marginally higher in another one from Scandinavia, and significantly higher in a third one. And I believe there was a Seattle connection here. This was based on psychiatric disorders from managed care coding not psychiatric interviews. So when you're reviewing the literature, please look at the definition of mild TBI, which is often queried, whether there's use of a control group in the study of children who sustain an injury not involving the head, or class and control for that matter. Outcome measures, were they with structured or semi-structured psychiatric interviews? Is there a prospective longitudinal design? Those would be some of the longer methodological issues. Was there recruitment from consecutively treated patients? Was there consideration of psychosocial and injury risk factors? Because you'll find, as I found coming in 20 years ago, that of the most biological of disorders, it's just traumatic brain injury, is not subtle like some of the other disorders that some of the psychologists and psychiatrists are working with here. There are lesions in the brain. Well, psychosocial factors are extremely important and sometimes the most consistent predictors of outcome. And are the studies adequately powered to test the hypotheses? Going to data on two papers from the same cohort that are in press at this point. And these are looking at onset psychiatric disorder after mild TBI. These are, however, all hospitalized patients, which is different to what I'm going to show you at the last couple of slides. So new psychiatric disorder 6 months after injury was surprisingly common in the study. This is a multi-site study. 25 out of 70, 36%, which is very scary. New psychiatric disorder was associated with frontal white matter lesions as opposed to other lesions, or just any lesion. Disorders themselves were heterogeneous, and this is typical of any psychiatric disorder study after TBI. There's no signature psychiatric disorder, no signature syndrome. Psychiatric disorder was associated with decrements in intellectual functioning, processing speed, express language, and possibly pre-injury reading. My view of this is that these were probably pre-existing. These were probably pre-existing tendencies in the children, because the best designed studies on mild TBI fail to show any difference in follow-up looking at these. So it may be that children who start off with marginally worse intellectual function, processing speed, expressive language, or reading are at greater risk. That's at least what this study suggests. Now, paper in press extends this a little further to new psychiatric disorder 12 months after injury. Here the rate's a little lower. It's 28%, 17 out of 60 children. Remember, these are all hospitalized children. So there was something that the emergency room doc saw to say these kids should not be treated as outpatients. They shouldn't be sent home from the emergency room, and they were hospitalized. And again, there's a generational effect here. This study was done about 10 years ago. Many more children are not being admitted to the hospital for cost issues and maybe for scientific issues, which makes it more important to not just study children who are admitted to the hospital, but those who are sent home as well, as long as they meet criteria for mild TBI. So in 12 months, new psychiatric disorder was significantly associated with socioeconomic status, psychosocial adversity, and all of this is pre-injury, estimated pre-injury academic function, then of course concurrent deficits, so tested at 12 months in adaptive function, academic performance, processing speed, memory, and expressive language. So similar findings there. According to people that if concurrent measures of adaptive function are not significantly different between your psychiatric disordered group and your non-psychiatric disordered complicated group, then beware of the results, because for most psychiatric diagnoses, one requires some evidence of impairment, and adaptive function is one measure of potential impairment. So this new psychiatric disorder was not associated with pre-injury adaptive function in this study. Injury varied within their mild range. Family psychiatric history, the pre-injury psychiatric disorder, lead location, as opposed to the 6-month outcome, gender or age at injury. Final, to this panel made me look at current data. We have an ongoing NIH-funded study looking at mild TBI versus orthopedic injury. And the difference of this study and all my previous work is I've never seen children who have been this mildly injured. Now, it's mild for me, but not mild for all the families who have been traumatized and the kids who have been traumatized. The design of the study, it's a one-year prospective controlled study. We're aiming for 220 children with mild TBI and 110 with orthopedic injury. The raters are blind to group. Raters of the psychiatric disorders are blind to group. The are at baseline within 2 weeks of the injury, 3 months after the injury, and 12 months with an MRI, with SWI and DTI and resting state functional MR. So far, we've enrolled 92 subjects. 24 out of 92, or 26%, are sports related. As I was pulling these data together, I was with, well, what is sports related? And this is something that I hadn't thought about, so I offer this to you. There were a number of other kids, about 6 or 7, who fell at home or playing around at school, playing basketball. Those we considered not sports related, and maybe should have, but sports related here are strictly in organized sports. I'll show you some of the numbers there. Kids are kids, and they play around and they fall, and we want kids to get off the couch and not and be outside and playing sports. But I think we have to come to a uniform definition of what is sports injury, and so I've added here that these are organized sports, and these 26% are sports related. Now, the latest findings at 3 months is that we've got a pretty good follow-up. 93% of the eligible kids came back. 57 out of 61 kids came back for a 3-month assessment. Psychiatric disorder in the TBI group was 7 out of 41, 17%, which is still pretty scary to think that these are kids who've been in the emergency room for an hour, 2 hours, 4 hours, and they've gone home. All these 4 had ADHD, and we're talking tiny numbers here, but I would emphasize there's no study that's been done. There's a couple of there's one study in Ohio which looked at post-concussion syndrome from a questionnaire and interview, but not specifically at psychiatric disorder. Beautiful study, and my study is designed after that, and the principal investigator is a consultant on this particular study. So kids developed ADHD, developed personality change, which is something like post-concussion syndrome. This is mostly affective instability. These are kids who are very irritable, anxiety disorder, and one adjustment disorder. And even one child in the orthopedic injury group developed a psychiatric disorder, and this was a needle phobia. And that's the importance of a control group here, perhaps an injured control group, one could argue that. Interestingly, this kid with the needle phobia had of needle. He was afraid of needles before, but it crossed the threshold to become a level of impairment for this particular child. And that, just to give you insight here, happened with some of the children with ADHD as well, that some had traits of ADHD, and the injury or course of time pushed them over the edge. So these precise sports which I pulled together for this talk, if you look at the bottom row, you'll see that soccer, I'm not sure I have a pointer here. Soccer is the most common one, 6 TBIs, children with TBI, injury from soccer, and 3 with orthopedic injury. And it's all over the map: lacrosse, basketball, baseball, football. Our age range is 8 to 15, so football injuries might be more common. You had a higher age range, I would say. Volleyball's in there, karate is in there. Recently, we had the issue of whether we should bring in a child with who's a boxer that had a mild TBI from some other mechanism. And interesting there, I decided actually to not include that particular child because it seemed that part of the purpose of boxing would be to get a head injury, to go for the head, whereas in football, the head injuries I see as incidental. That can be argued and criticized, but there you can see methodological issues all over the place. So in terms of indications here, mild TBI and the new onset psychiatric disorders, I think we need to screen for new psychiatric disorders, not just academic difficulties after injury. Very few child psychiatrists dealing with traumatic brain injury. I think that your recommendations to the government could change that, but there's a power shortage, and it's easier. There are a lot of more people who look at academic difficulties and neuropsychological issues. Focus maybe on higher risk children with those with frontal white matter injury, those with marginal pre-injury academic function or decline in school function. So if you see that there's a decline within the first few months, those are the kids we should look at carefully to see if they're developed a psychiatric disorder. And of course, the study that we're doing right now is the pending results from this large study of consecutively treated patients and outpatients with mild TBI. So we're not excluding them if they happen to be admitted to the hospital with age, gender, and SES, socioeconomic status, matched injured controls. For study here, it has to go to the nursery rhyme in your literature reviews. I think you should include this. The ancient knowledge here is relevant. So Jack and Jill went up the hill to fetch a pail of water. Well, you know that this is not true. They were lying through their teeth and probably had oppositional defiant disorder because water goes downhill. You don't go to the top of the hill to fetch a pail of water. Jill down and broke his crown and came tumbling after. So Jack had a linear skull fracture. It would have met criteria for inclusion in our study. And Jill had an orthopedic injury, at least a scrape. Well, gotten home to trot as fast as he could caper. Tough to he had pre-injury ADHD or post-injury ADHD, but he was capering really fast. He went to bed and plastered his head with vinegar and brown paper. And that was a discredited managed care did not pay for that. It doesn't work. Now, the last verses are not known to many people. When Jill came in, how she did grin to Jack's paper plaster. There was some family dynamics here, which got a lot worse when her mother, vexed, did whip her next for laughing at Jack's disaster. And unfortunately, we had to include Child Protective Services here, and there are all sorts of family issues. Now, Jack laughed and Jill did cry. This is not pathological laughter or pathological crying. But her tears did soon abate. Things rectified themselves. Then Jill did say that they should play at seesaw across the gate. And here we deal with something that's really considered in studies about the risk of re-injury, which is very important. Children who have one injury are likely to have a second. Thank you.
All right.